All right, good evening, everyone. We'll get started here in a moment. We want to make sure that everybody gets logged in and that their audio is connected. Um, we're processing about 50 people coming in right now, so we'll just give it a second here before we get started. All right, it's kind of evened out, so we'll go ahead and start. And so good evening, everyone. My name's Garth Reynolds. I'm the executive director for the Illinois Pharmacists Association.
And my name's Chris Crank. I'm the Executive Vice President for the Illinois Council of Health System Pharmacists. Welcome tonight. We have a group so far of about 75 people on the call, so that's an excellent number of individuals looking to hear a little bit about the plan for tomorrow.
Well, and I greatly appreciate everyone joining, whether you're going to be able to be in person at Legislative Day in Springfield, or you're going to be participating virtually from your practice. And that's one of the great things about our technology these days. We're able to have everybody participating throughout the entire state. So we're going to go ahead and shift over to our slides. And once we get to a break point in here, I will put them into the chat. But they will also be available through, whoops, they will also be available on the Legislative Day resources. All right. So again, welcome to our 19th annual Pharmacy Legislative Day, and for tonight's briefing on covering the topics for our Legislative Day for tomorrow. I do want to point out, and we'll thank them again tomorrow, but we do have some overall sponsors, not only just for this program, but our overall advocacy sponsors for our organizations. And as you see them there, if you interact with anyone from these organizations, from McKesson or Astra or IPC, Walgreens, Pfizer, NACDS, please thank them. What we're able to do tomorrow and the support to be able to bring that event together is all from parts of their support throughout the entire year. So we do want to thank them for those efforts. So as Chris and I already introduced ourselves, I do want to, as we start tonight's call, kind of do some basic 101s, mainly as a review for some of you. And some of you, it may be brand new information, and that's okay. And we're also doing this because tomorrow we will have some guests coming in and out of our orientation. So it allows us to take some of that out of tomorrow and do it tonight. And one of those aspects is just reviewing how a bill becomes law. And so this is the easy process, and I am being sarcastic when I say that, of how a bill becomes law. It is a linear process for the most part, but as with most things, there are different rules where bills can kind of move around the process if need be, but we're not going to get into those complexities. Really just want you to understand the process of how a bill becomes law. And for tonight, we're just going to use a very easy, quick example of, let's just say we have a simple bill that wants to amend the Pharmacy Practice Act that says that all pharmacies would close on 6 p.m. on Sundays. Well, all bills like this one would be an idea, and ideas have to start and get formulated into a bill. And that's where all ideas, whether they come from an organization like IPHA or ICHP, or a senator or representative, they go to the Legislative Reference Bureau, or you'll hear us refer to it as LRB. And LRB helps with providing a team of attorneys to take all these ideas and put it into a format for the Illinois compiled statutes to make it appropriate for a bill. And they then present the bill to a representative or a senator. In our case, for this example, it's going to be a representative. And the representative will submit this bill to the clerk of the House. Or if it was on the Senate side, it'd be to the Secretary of the Senate. So the clerk of the House will do what's the first reading of 3. Every bill has to be read 3 times. And so the clerk will read it, and in the first reading assigns the bill number. For ease of our example, we'll say this is House Bill 100, and it's an act concerning regulation. That's considered reading of the bill. We don't physically read and literally read the bills entirely anymore into the record. Then these bills get put into a gigantic bucket for all intents and purposes called the Rules Committee. In the Senate, it's called the Assignments Committee, and that's where all the bills go through. And you'll see later on, we'll have a slide of the thousands of bills in both chambers right now that are being considered and want to be heard. Well, in the Rules Committee, its members are made up of the minority and majority parties, or the Democratic and the Republican parties, and they help decide which of the variety of committees that these bills will go through. In the House, we're fortunate because we have a committee that just handles healthcare regulation bills called House Healthcare Licenses. And so a bill like this that would amend the Pharmacy Practice Act would go to this committee. Now, committees are vital for the life or death of a bill. And from an organization advocacy point of view, it is the best place to either advocate to move a bill forward, to change a bill if we feel it needs to be perfected, or if to oppose and kill a bill if we feel that it is something that's against our respective agendas. Because in House healthcare licenses, I don't recall the exact number this year, but they've had, I believe last year's number was 8. So we only need to influence 5 votes. And that's a lot more than when it gets to the floor, when we need, we'll have to start talking between that 60 to 70 number, depending on what's needed for the day. So we get this heard in committee. Committee seems to be approving of the idea of all pharmacies closing at 6 p.m. on Sundays, and they pass it out of committee with no changes. Now it goes to the House floor for what's called second reading. This is the second and last time in this chamber that a bill can be amended. And if it does get amended, it does need to have that majority of the 118 of them, or 60 votes. So the bill isn't amended. It goes to what's called third reading. A third reading is what you normally consider to be debate. When you think about senators and representatives arguing on TV or in movies or on the news, that is third reading. So in this case, the House hears the bill and they think this is a great idea and they want to move it forward. So they go ahead and move it 118 to 0, and it goes across to the Senate. Now, the Senate, you would think, does this bill go automatically to the Senate floor for debate? The Senate says no. We are an equal component of the check and balances of the legislative branch, and we want to have this bill go through our process as well. So it gets put back into that gigantic bucket again. So not only the bucket has all the bills that are being considered in the Senate, it also all the bills that are coming over from the House are in the same gigantic bucket. And so this bill then gets assigned, but the Senate, having only 59 senators, has less members to have more extensive committees. So all of our bills in the Senate are put in what's called License Activity Committee. And this is all the healthcare professions, but also architects and landscapers and barbers, all the other occupations and professions under DFPR or under licensed activities. Well, when it gets to this committee, there had been discussion amongst pharmacy stakeholders and other advocacy organizations to amend this bill. And this bill was saying, well, we're not opposed to the pharmacies closing at 6 p.m. on Sundays, but we do want to put in an amendment that would restrict this, that would put an exception in for mail order pharmacies, long-term care facilities, and health system pharmacies. And so they would be carved out of this requirement. So the committee discusses that and they approve it. And now it moves to second reading in the Senate. There's no further amendments, and it goes to debate on the floor, and all the senators agree with the amended bill as presented, and they voted out 59 to 0. Well, now we've got an interesting situation. We have a bill that has passed both chambers, but it's really 2 different bills now. We have the original bill from the House that says that all pharmacies are closed at 6 p.m. on Sundays, and we have the bill from the Senate that has the exception for mail order, long-term care, and health system. So the bill from the Senate, just that component that was amended, has to go back to the House on a process called concurrence. And the House will review that and debate that in committee and bring it back to the House floor for a recommendation. And if it is agreed upon, then the perfected bill will then move to the governor. Now, our governor, just like the president, has the ability to pass or veto a bill. But on a federal level, the president can only total veto a bill, where in Illinois, the governor has three different options: total veto, which is the same, kick it all the way back; item or reduction veto, where they can make changes of maybe move out mail order pharmacies; or a mandatory veto, a legislative like function where they can go, you know what, I love this idea of closing 5 p.m., but I want to make it all days of the week. Well, whatever action would be taken if there was a veto action would have to be overridden by 2/3 of both chambers to override the governor's veto. But in this case, the governor likes the idea and signs the bill into law. So that's kind of a very quick overview, but there's always additional rules, things that can happen. There's things that can complicate this, like shell bills, but we're not getting into all of those other pieces of the chess puzzle or chess game at this stage. But I'll turn it over to Chris to kind of go through some of the general demographics of what we're seeing right now in the 104th General Assembly.
I think, one of the things you might look at that process and say, well, that makes it really hard to get a good idea or a change that we want into place. And that can be true, right? There's a lot of discussion and a lot of process that has to be gone through. But I think the thing we always have to remember is it also prevents bad ideas from moving quickly too, right? So it's purposefully a little bit of redundancy in both chambers and a little bit long in the process to make sure that we really have good consideration of what's being proposed. In the 104th uh, General Assemblies are 2 years, by the way. The 104th General Assembly will be 2025 and 2026. That confuses a lot of people, but it is a 2 year period. We still in Illinois do have a Democratic supermajority in terms of having in the Senate 40 Democrats with 19 Republicans, and in the House 78 Democrats with 40 Republicans. Um, it's some states we just were Garth and I were just at a seminar where we found out that some states like Montana have 30 days of session or 90 days of session, excuse me, ev once every 2 years. We pretty much have from January until, let's say, around June, where the main legislative session is happening and bills are being discussed. Maybe ended a little bit earlier in May, but there's still things in June that are going on and beyond. But you can imagine if you only have 90 days every 2 years, the number of bills probably aren't huge. We already this year have 6,485 bills that since like January 8th, if I'm remembering correctly, was when
Yep.
bills started to be filed. We have 6,485 bills that have been proposed for Illinois in the Senate and the House. And we're typically between ICHP and IPHA, we're typically looking at about 300 bills that might impact, right? Pharmacy practice, healthcare in general in Illinois, or what I would call pharmacy parallel issues that have an impact on pharmacy. And so we are, in terms of that supermajority, there are ways that we can leverage that and look for how to do things. But one thing I always want to say, when Garth and I feel like I can speak for both of us, we work with anybody who is willing to be pro pharmacy and to help our patients and get things accomplished for
Absolutely.
patient care and for pharmacy. And so I think, it's one of those things sometimes we might tend to, when it's a super majority, you do have to work with the Democrats a little bit more. I just don't want anybody to think that that means we don't work with Republicans or legislators on that side of the aisle because we work to get things done for pharmacy and for patients. I don't know, Garth, anything you would add to
No,
that?
I would agree with that. And that, it's hard for sometimes whenever we have good ideas from a Republican, and some of them have some really great ideas, and it's more of them trying to bridge and, well, one, depending on which Republican legislator it is, and then seeing what we need to do to maybe bridge in some bipartisanship to help get that idea across. And
And
go
oh,
ahead.
no, I was just going to say, and the other thing with bills, a lot of times they have good intent,
Hmm.
but the operationalizing of those bills is where they struggle. They're not feasible. They won't actually be able to accomplish that good intent that they go for.
Well, and I think that's where the key is, where both associations are key in that education, not only of staff, but also of the legislators themselves. A lot of times they will call either one of our organizations to kind of go, how do we handle this situation? Or is this a situation that's already addressed in law? And so a lot of times they're asking for our assistance. And that's where, I always go back to that one, my example that, advocating is a lot like patient education. And there's a lot of ways where you can sit down and build that relationship and help educate and or in our case, advocate for the changes that need to be done. This is just a quick list of some of the General Assembly committees. And it is not an exhaustive list, but just kind of gives you an idea of some of the committees where those bills get sent to for further committee hearing. And the ones that are highlighted there are probably the ones that we deal with more on a regular basis. Like tomorrow morning, for instance, healthcare licenses is meeting, but luckily the bills that would be that are impacting our profession aren't being called tomorrow. And but it is something, these committees meet usually on a weekly basis. Now, some committees like prescription drug affordability may will only meet when it's needed. So not all of them are on a regular basis, but like right now, healthcare availability and accessibility, healthcare licenses, insurance, they meet on a regular basis. And then once the budget really starts to roll through its processes, the appropriations committees will start gearing up. Chris, anything you want to add there?
No, the only thing I would say is sometimes, especially if one of your particular elected official is the head of one of these, right, or the chair of one of these committees, that's a really good opportunity as a constituent and as a pharmacist or a technician to interact with your association and try to, talk to that leader or that chair in those positions.
One thing that I usually, when I discuss the process with students, I always remind them that when we pass a bill, that's not the end of the road. And a lot of times it's the very beginning. And that is a reminder, like we have the Pharmacy Practice Act, but we also have the Pharmacy Practice Act rules. So after bills pass, we advocate and continue the work with working with the various executive departments under the governor's office. And these are just a selection of not all departments under the governor, but the ones that we primarily deal with here. DFPR, of course, is where the Board of Pharmacy sits under and deals with all of our licensure issues. HFS for all of our Medicaid concerns. DHS with the prescription monitoring program and some regulatory aspects of the Controlled Substance Act. Of course, the Department of Insurance with our managed care and PBM concerns. Department of Public Health for our vaccines and immunization and eye care interactions, but also our two active and one coming statewide standing orders on naloxone and contraception, and the one that's coming on HIV, PrEP, and PEP. And then, of course, Illinois CMS, Central Management Services, deals with a lot of issues concerning the state employee and retirement programs. And one department I forgot to put up here, but we do occasionally have programs with is Department of Aging as well.
And I think this highlights, a lot of times there's confusion, so I think it's good to cover, Garth. Laws are made by, right, the legislators and the governor, right, in terms of that process you just saw. Those are the laws. What I always do when I'm talking with students is I talk about policies and procedures. The laws are analogous to the policies, right? What do you have to do with controlled substances? What are the requirements around them? The regulations or the rules are more of the procedures. What are the details behind how you stay compliant and you do the things that you're supposed to do? So, like IDFPR, when we're looking at our Pharmacy Practice Act, right? The legislators produce the act, right? They get input from people and that comes out of law. The rules, Part 1330, that comes from JCAR. We're going to talk a little bit about that here. We moved right into the slide. Um, the Joint Committee on Administrative Rules, actually the general counsel from the department, like IDFPR, for instance, the lawyers work with the board. They work with Garth and I, with the associations to draft rules that then get published. So I just think of there's laws, which are what we're talking about tomorrow. These bills have the potential to become laws. The regulations are set by the department that it applies most to, along with, in our case, Joint Committee on Administrative Rules, when it would come to the Pharmacy Practice Act. So those rules, right? They are initially published in the Illinois Register. It comes out every Friday. And the first notice is the opportunity for the public to comment. So any person, any citizen of Illinois can comment on any of the rules that are published on first notice. Usually you'll see maybe 4 pharmacists and then Garth and I that might provide some comments on pharmacy rules. But every pharmacist and technician on this call, as a citizen of Illinois, has the ability to provide comment on the rules when they come out. There's a minimum of a 45-day period where the public is allowed to provide comment. It's usually a lot longer than that. So usually it's a minimum of 45 days. It can go longer. The department then hears those comments, incorporates some changes that they think are appropriate, or provides those recommendations to the Joint Committee on Administrative Rules, and they reevaluate those rules, and then they get published in second notice. I think one of the important things to point out about JCAR, the Joint Committee on Administrative Rules, it's made up of 6 senators and 6 representatives, each of which have 3 Republicans and 3 Democrats represented. So the goal of that is to have a balanced representation when it comes to rule writing. And so once they're published in second notice, then there is basically the opportunity to, there's no more opportunity to comment, but there is a timeline within 45 days minimum, those rules could be in effect. Sometimes it takes longer than that. Again, we've had rules that have taken a year and a half to be finalized. So
Yeah.
it's not always 90 days. It can be much longer. What do you want to add to that, Garth?
I was gonna say, no, I think you covered it. And it can be the very frustrating part about rules because it does take a long time for that process. Once it starts, it can be very laborious to us to get to a final solution, especially if comments keep going back and forth, or if JCAR feels that the departments need to consider more of the public's concerns. And so it can be an extensive process, but that's also one of the reasons why I'm appreciative from an association point of view that the department works with the associations and tries to get through a lot of the issues before we get into the public comment period on the most part for a lot of things. And so trying to shorten that as much as possible, but it still has to go through the public comment. The public do come up with some great ideas that may not have been thought of by others, and have their due diligence to need to be considered as well.
The other thing with it, when you're talking with your legislators, they are concerned about rules and things that you think aren't right. But remember, they're not the ones that are actually controlling those rules. So you want to talk to your board of pharmacy members, right? So you'd want to reach out to the board of pharmacy, reach out to the associations, IDFPR, right? If you have a major issue with the rule, because they are usually the ones that will try to redraft or hear those concerns for JCARD, again, reconsider those rules and fix those rules.
Yeah. And I just added this slide here, and this is just kind of a general slide just to show you when we're looking at legislation, we're not just looking at legislation proposals that could amend the Pharmacy Practice Act or the Controlled Substance Act. There's numerous other acts that impact our profession, and this doesn't even include the Illinois Insurance Code and the Illinois Public Aid Code and the significant regulations under like long-term care and hospitals that are under the Department of Public Health codes. And so there's a lot of different aspects of legislation and law that can impact our profession and how we deliver patient care. So that's why it's so vital for us to be monitoring these processes and advocating for needed change. So we're going to take a quick review of our items for this at this legislative day, and it's going to be a little bit different than years past, mainly because we're talking more on the advocacy of ideas and what we're hoping to see out of legislative packages, and we'll talk about that. But I know not everyone may have been able to hear Governor Pritzker's State of the State address, which was actually last Wednesday. But there was an important section of his address that will lead us right into legislative day. So we're going to play that for you now. And hopefully there won't be any pesky ads whenever I try to play this.
Dollars per year. This year, we're going to need to do even more to address high prices and counteract Trump's tariffs that will raise taxes on working families. At the top of the list, we need to lower healthcare costs. One of the great ironies of our modern age is that breakthroughs in research are producing medications that can treat and even cure long-standing chronic diseases. But the high cost of these drugs are making them unaffordable for people who need them the most. What's causing that? Well, patients, healthcare providers, and independent pharmacists will all tell you that pharmacy benefit managers, or PBMs, are driving up prices. PBMs are middlemen in the healthcare industry. They extract extra profit from patients through opaque and often predatory tactics. They are not doctors, but they work with insurance companies to deny people the drugs and treatment doctors prescribe. Not only are they driving up healthcare costs for Illinois families by hundreds of millions of dollars per year, but they're also putting small, local, independent pharmacies out of business. Michelle Dyer of Macoupin County is a pharmacy owner. Will you please stand and be recognized? Oops. Michelle was forced to close 3 of her stores after years of skyrocketing PBM fees. Her livelihood was threatened, and so were her patients. She's not alone. We're talking about rural small businesses being ruined by large pharmacy store chains that own PBMs. Michelle and all the independent family-run pharmacies are under threat, and they deserve a level playing field. That's why I'm introducing the Prescription Drug Affordability Act to rein in the unfair practices of PBMs, reduce drug costs for Illinois patients by hundreds of dollars per year on average, and protect independent pharmacists. We'll also give full statutory authority to the Illinois Department of Insurance to examine the books and records of PBMs and require them to submit to annual reporting and auditing. We're going to end the overcharging for drugs that people rely on, from insulin for diabetics to chemotherapy for cancer patients.
So there was a comment in the chat about could we send a link to the video, and Chad, I'll work with you on that. We did pull this out of the state of the state for the purposes tonight, but I can help share you where that link can be found. But on the aspects of hearing PBM reform, or let alone a pro-pharmacy agenda item elevated to the level of a governor's state of the state, is monumental. And I hope we can kind of enjoy that moment as we push forward with the hard work ahead, starting for tomorrow's legislative day, and for hopefully our success this session in getting comprehensive PBM reform accomplished. For those of you who've been longtime advocates in pharmacy, whether it's been through your practice or even as a student, this is paramount for the survival of the profession. Unfortunately, the business practices of PBMs have gotten to such an extent, and it has crawled its way into all the different crevices of our profession, that it's starting to crumble our foundation. And so what we're talking about for tomorrow because, as the governor said, he's going to be proposing a piece of legislation. It has not been introduced as of yet. So what we'll be talking about is endorsing and applauding the governor's focus on PBM reform and asking for what we continue to see and advocate of, and extending upon what we were asking for with last year with similar legislation, that we want to ban spread pricing across the board. That we need to see fair pharmacy reimbursement using a NADAC plus professional dispensing fee model, and that has to be for all pharmacy types in affected by PBMs. If we continue to help one sector over another, that just delays the inevitability of the crumbling of the infrastructure and puts more pressure on pharmacies, because we're in a situation now, and I'll give you an example from one of our members up in the west side of Chicago who had a store closed near him, or actually four chain pharmacies announced that they were going to close near him. And he's in a neighborhood that has a lot of higher percentage of Medicaid and Medicare. And, whenever a pharmacy would announce closure, a lot of us as good business people would say, great, I got more business coming in. Well, when it's mainly Medicare and Medicaid, with the reimbursement levels that we see of those prescriptions, those actually are death spikes for a pharmacy to try to take on. And so it's hard for a pharmacy now to be able to take on more of their share of what their community needs them to do, and be able to do it adequately with trying to keep the business open. And that's the situation we're in. But luckily, advocacy has worked. It's taken a while. For those of you who've been around for a while, we've been talking about this in Illinois for well over 2 decades. And on a federal level, it was even slower getting momentum. But if you know right now, if you've been following both the federal, in addition to what's been going on here in Illinois, we've had 2 FTC reports that have exposed the business practices. Now, granted, from our point of view, we've been talking about this for years, but a lot of times governments have to go back and do their own homework. And just like with what we showed here in Illinois with the Auditor General's report 2 years ago, that showed that all of the PBMs under the Managed Medicaid program misappropriated the $200 million that was supposed to go to pharmacies. That was money that would have kept some pharmacies open that closed during that time. And that money's still being stolen and misappropriated today because the state hasn't fully acted on that audit report. But if it was a single pharmacy that had done 0.1% of what those PBMs have been shown and proven to have done, those pharmacies would have been brought forward to the Board of Pharmacy, stripped of their license, and be banned from Medicaid, and be looking at prison time and financial penalties. We have to make these changes as we go forward. So in addition to our 2 first points is enforcing pricing transparency, also regulating specialty. As we all know as pharmacists, there's not a legal term for specialty. That is not an FDA term when no drugs are approved. Yes, there are risk and benefit, risk mitigation that has with certain medications, but for the most part, a lot of medications can be provided by a properly, adequately trained pharmacy. And of course, increase oversight by the Department of Insurance and Medicaid over these contracts to allow the state to have the power over these contracts. That's half the problem, not only in Medicaid, but in the state employee program, that they don't have that power, and they need that. So we're hoping to see these reforms as we move forward here to ensure affordable and accessible health care through sustainability of pharmacies as we go forward in the long term. And I'm going to go ahead.
One of the things, Garth, that I just want to say, number one, it's always good when something like this is brought up by the governor and the state, like Garth said. I think if you would have even said 4 years ago when we were talking to legislators, when you said the word PBM, they had very few of them, not all of them, but very few of them would have known what we were referring to. Now, I feel like so many more legislators understand. The other thing, because they've heard from us, They've heard from constituents, they've heard from physicians, they've heard from health systems, they've heard from independent pharmacy owners. They've heard from everybody but the PBMs about the problems that PBMs are causing. The other thing I want to emphasize, while, we're very, for independent pharmacy owners, this is necessary now. I don't want anybody to think, though, that this isn't important to health systems now either. Um, you know, it's not just inpatient care that happens in health systems anymore, right? There's a lot of outpatient prescriptions and infusions and other things that are occurring within health systems. Those infusions more and more are being pushed towards PBMs, right? Instead of being under the medical benefit. So I think I just want to say, know that your health system pharmacists are very much partners on this. It's very much an issue that affects all of those practicing pharmacists and organizations as well. And I'm really, it can't be a bad thing that the governor brought it up on the state of the state.
Well, and to add on to that, Chris, you brought up a really good point about legislators know what PBMs are now. There are a number of newer legislators that you may engage tomorrow that may not be as aware. And so that's where this comes as a good time of education, because they're newly elected, but they're learning very quickly. One thing to also bring up for this, whether it's PBMs or pharmacy deserts, these are terms that are now common terminology in the General Assembly. And legislation not brought forward by IPHA or ICHP that are being brought forward by members of the General Assembly to try to address in their own ways these issues. There are at least 2 bills that talk about pharmacy deserts, and there are at least 4 other PBM bills. None of them brought forward by either organization, but brought forward by the General Assembly because of your advocacy. I also want to point out that it wasn't reflected very well in that video. The PBM discussion and the announcement of that this was going to become an agenda priority for the governor was one of the largest standing ovation and celebrated remarks. And this is the one, if not very few, true bipartisan issues in the General Assembly. We have sponsors, at least one of the other PBM bills is brought forward by a Republican in the House. So this is a bipartisan issue. Even on social media this week, we've had strong pro-pharmacy advocates applauding the governor addressing this in his speech from the Republican side, and showing some of their pictures that they posted visiting pharmacies in the southern part of the state and saying that change needs to happen. So this is a great momentum time. And again, we're at this point right now because of you and your advocacy and building this crescendo of our voice that it has to be heard, and it's being heard right now. And this is why we have to all come together and push hard. Go ahead, Chris.
So one of the other priorities that we have, for a couple of years, not as long as PBM reform, although this is related to PBM reform.
I say it's PBM adjacent, definitely.
Is Senate Bill 1746. And Christina Castro, Senator Castro, has once again introduced this bill for us. And really, this would address the mandated white bagging that insurance companies and PBMs are requiring on infusion centers. Just so everybody, I think a lot of people I know have been at Ledge Day many years. White bagging is a process that eliminates the physician's office or the health system or infusion center pharmacy from being able to provide the drug from their supply. Many times what is required is the health system or the infusion center or the physician's office does all the prior authorization work, does all the hard background and patient care. Then what happens is the insurance company, their own pharmacy, right? Their pharmacy that's either owned by the PBM or by the insurance company gets to fill that medication, and then it's shipped to either the institution in the case of white bagging for use for that patient, or believe it or not, there are still some instances where that drug gets shipped to a patient at their home to then be brought into the physician office, to be brought into the infusion center for use. Long story short, this generates all kinds of patient delays in terms of their therapy. It has resulted in issues related to destruction and waste of drug. The number of times we've heard about drug freezing on the dock or being exposed to extreme heat, or like I said, extreme cold, files that are broken in shipping because they're shipped in FedEx boxes. They're not shipped in special containers, believe it or not. Sometimes they are shipped right along with Amazon orders and everything else. The other thing is, right, it's clinical care of patients, and that's really what's most important, right? And a patient comes in, they've taken a day off of work, they have to find childcare, like other things, right, to make this appointment, let's say. They come in and they get their labs that morning at the office. And lo and behold, that therapy is no longer appropriate for that patient. You would think in that scenario, the insurance company would say, or the PBM would say, okay, let's go ahead and let that patient get that, the alternative drug, they can get it from the pharmacy. Very often they say no. The prior authorization process has to start over. The drug has to be shipped from that PBM or insurance company's specialty pharmacy again. And the patient, in the end, their therapy is delayed. They've wasted a day off of work and they have to come back and reschedule and retime everything to have that appointment. So this is not good for patient care. Where it gets sticky is in the economics. Of course, the health systems and the physician's office and others want to be paid for the drug and for the service. The argument that is made is that the cost is too high. The standard approach that we would say is that should be done through contract negotiation and discussions, not by making the patient get their drug shipped from an outside pharmacy that doesn't take care of them. So what would this bill do? This bill would prohibit insurance companies and PBMs from being able to require that the white bagging process be used. And so health systems, infusion centers, and physicians' offices could push back and say, we don't think that is the best care for this patient. We will fill the drug from our pharmacy. You can't prohibit us from doing that. And we will work on contract negotiation on reimbursement and what that looks like.
So any questions on the first two issues? Well, look like we have a hand up, sorry. Shannon, I'm gonna go ahead and hit the allow to talk button. It should unmute you. Go
Okay,
ahead.
I think that worked.
There.
Yeah, so I'm Shannon. I've been working with Chris for a while on white bagging. So thank you, Chris, for that intro. I just wanted to also point out that we do have a new federal the Drug Supply Chain Security Act to improve safety standards. We are required to scan all inventory into our infusion centers, and these patient-specific prescriptions that come from all over do not have the safety pedigree that the manufacturers have to comply with. So this is a safety issue. We don't have lot number tracking. So if there were to be some sort of outbreak or infection, we would actually have no way of knowing what we actually gave to this patient. So it really is a safety issue from a federal standpoint. And yeah, I just also want to point out we kind of mentioned the medical plans and the PBMs, but really this is about United Healthcare owning Optum Pharmacy, right? They're mandating that they go through their own pharmacy. So essentially they are profiting on their own patients. Otherwise they wouldn't have suggested this to employers. So I just want to throw that out there that this is PBM driven as a way to drive business to them. It's not truly to save the employer money. So just throwing that out there. Thank you.
No problem. Thank you. I saw someone else had raised their hand. If they wanted to be recognized, we can unmute them if they want to raise their hand up again. Chad had put into the chat. So is this a violation of the DC DSCSA, it's something definitely to be considered as a comment back to the FDA about if this is proper tracking and notification between partners. But I think it's just exampled here and brought forward that there are a lot of patient issue concerns here.
And the reason why is, right, the transaction history, the 3 documents don't come from the specialty pharmacy when they ship it. And so it does increase the risk potentially, right? How does the health system or the infusion center guarantee that that product, when it arrives at your door, is in fact not counterfeit, right? That it's legitimate product. When you order it through McKesson or AmerisourceBergen or Cardinal, you get the documentation to be compliant with the Drug Supply Chain Security Act. You don't get that when you get the drug from the outside pharmacy.
Any other questions on our first 2 issues?
I
Okay.
guess like what is the focus of PBM reform just for the students? Because that's such a broad term. So I guess what is the
Yeah,
like what exact reform, should we advocate for?
so our reform and what you'll see on the talking point sheet for tomorrow is kind of hitting on these 5 points in addition to the reforms that we're asking for white bagging. And it's mainly because, there's not a bill yet. So it's kind of hard to put all of our focus behind with talking with the legislators that we need you to support X bill, whether it's in the Senate or the House. We're kind of riding onto the trail of the governor's speech saying we need PBM reform, and for comprehensive PBM reform that we hope to see in this package, we wanted to address these 5 main concerns: banning spread pricing, increasing transparency, fair reimbursement, the elimination of specialty drugs, and more oversight on contracts. Because and I know back on the transparency, one of the key points here is that we want 100% of rebates to go back to the employers and to the plan sponsors, ultimately to the patients. There's so much hidden money that's being stashed away by the PBMs that's rightfully the plan sponsors, just like the money that's being stolen from pharmacies through spread pricing. There's so much in savings, and it's good to see an advocate in this respect from the governor's office, and seeing that the governor understands this complexity and these unethical business practices and how they have an impact not only on pharmacy and healthcare infrastructures, but the quality of care to patients. And that's where we got to drive that home, that this is raising medication costs. Because one of the things that will get thrown back at us by some tomorrow is that, well, if we pay pharmacies appropriately, isn't that just going to raise costs? No, the money is already there. It's just we're redividing the pie that's already been allocated. And so we're just asking for should be happening in a fair contracted environment to be done here, because government's cost of inaction has hurt patients, has raised their medication costs over time, and has slowly eroded the healthcare infrastructure. So it's our key points tomorrow is hitting these 5 points that we need to have comprehensive PBM reform. And we've done a lot with knocking down various aspects of PBM reform over the last 4 or 5 years, especially with Governor Pritzker in office. But these are the major key components. Now, what want to be very clear about, let's say we get this list of everything on here accomplished, and white bagging, and any of the other issues that we want to add on to this for 340B. Are we done with PBMs? Unfortunately not. I wish we would be. Hopefully we'll have some federal legislation that will back up what we're talking about here, that can kind of help lay out a solid framework for us to work in the states. But unfortunately, PBMs are very sly. We've already seen that. White bagging is a great example of all this, that there's additional ways that we've got to keep an eye on them to make sure that they don't try to rename something and come back and try to hurt patients and pharmacies again through another mechanism. Harry, I see you're up. Let me hit unmute here for you. You should be, Harry, if you can, There you go, Harry. Go ahead.
Um, First, thank you very much for this presentation. I do appreciate the time and effort that both you and Chris have put into making this kind of day so special. And I'm also very thankful I'm able to attend this year. Um, I want to at least touch base on the impact of having the governor being able to speak on PBM reform and not only speak about it, but also detail um, the core issues that all of us at IPHA have been shouting from the rooftops for the last, what, 5 years?
At least, not decades.
With that in mind, a lot of the constituencies that I will be talking to
Mhm.
are on the opposite side of the aisle that Governor Pritzker is on.
Yeah.
And I would only imagine competing lobbying efforts will potentially capitalize on that in this discussion that we'll have with legislators tomorrow. Is there something that uh, Garth or Chris would have as far as comments of how to be able to combat any potential misinformation that might be happening there?
Well, there's a couple different ways that you can address that. One, like I said earlier, this is one of the true bipartisan issues. And that's on a federal and a state level. On a state level, I would remind House Republicans that may push back that there is a House Republican bill, brought forward by Representative Cabello. And I was referring on the Senate side to comments and social media posts by Leader Fowler on the Senate Republican side. And so I would encourage any House members to talk with those respective members about sharing their concerns and why there needs to be need for comprehensive PBM reform. And it is a bipartisan effort. And we look at that just whenever we've had our issues on PBMs come, when we get it to the floor, almost everyone's behind it. And if with the Republicans that you still have a little bit of push, you can remind them on a federal level that there is some support from the current White House administration on PBM reform, and that's been longstanding in President Trump's first term. Not as extensive as we would have liked, but there is renewed efforts, and hopefully here in coming weeks we'll be seeing some federal legislation on PBM reform if rumors continue to be tracking. So, but also I would encourage to get them into your store or get them into a store, and we can help work with that and get them um, to see the claims, because a lot of the Republicans, they're seeing it from a business angle. And if once they see the numbers, it should start to click. But we'd be glad to, whether it's from IPHA side, myself or Donnie, to help kind of talk about that. And I'm sure with Chris, with Liz and Sam, would be glad to help out as well.
The other thing that I would say is pharmacy deserts don't care whether it's a blue area or a red area.
Yep.
Um, right? Politics like to pit those two areas against each other. Chicago is all the problems, or downstate, just it's rural and we don't need to worry about it, right? We don't really feel that way. I just want to know I'm being sarcastic there a little bit. Um, Pharmacy deserts are affecting access to care in urban areas and in rural areas. And if they want their constituents to have access to health care, PBM reform is necessary. So, I mean, I think you can also go back to their constituents. The people in your areas and how pharmacy closures are impacting them. That's something that a legislator should care about, whether or not they're Democratic or they're Republican too. So I would focus on access to healthcare.
Thank you both.
So go ahead, Garth. I was going to
No,
say,
no, go ahead. I was just answering items.
oh, you're answering some. So in terms of some of the other, we do have a couple of other bills to kind of touch base on, right?
Yeah.
In terms of importation.
Yes, and this is again where we're taking a different tactic than what we've done in the past. The next couple of slides are on importation and healthcare availability boards or prescription drug affordability boards. And normally these are bills that we come out hard against. And it's not that we're still not against them. What we're actually, and what you'll see on the talking point sheet tomorrow, is that we're advocating for proven PBM reforms. Because we know where legislation like importation and PDABs have been passed in other states, but they have not proven themselves to bring down costs and increase medication access. And if anything, it's been the exact opposite. So we're recognizing that these are medication cost reforms, but we feel that we should be focusing right now on comprehensive PBM reform, as we mentioned earlier. But I'll
These
Chris,
are the
tackle importation. I'll do the other one.
Yeah, sure. But I mean, I think these are prime examples of good intent,
Mm-hmm.
but when the rubber hits the road, they don't accomplish that intent, right?
Yeah.
So when it comes to importation, we could spend another half an hour. Don't worry, I'm not going to. Talking about this, but I mean, there's multiple reasons why importation of drug from Canada doesn't work. Number one, you can look at the population size, right? 30 million versus over 300 million. So if Canada gave us all their drug that we had that was short in the United States, how does that work? That's federal level, but even if you look at the population of Illinois, 12.7 million people in Illinois, there are 30 million people in Canada, right? We're a third. We'll call ourselves a third of the size of Canada. So there's issues there. There's also safety concerns, right, with importation of drug. We're back to Drug Supply Chain Security Act. How does that work? Barcodes in health systems don't work on Canadian products. First Data Bank and all the barcodes aren't set up to work with foreign product. We've seen that time and time again with drug shortages where we're allowed to import drug from Europe, import drug from China, other places. Barcode safety doesn't work. The other thing is there's a loophole in Canadian law where pharmacies can import drug for distribution to anybody outside of Canada that doesn't have to meet the Canadian standards for drugs. So in other words, right, if it's the pure Canadian drug that's imported for Canadian use, you can feel reasonably confident in that ingredient. However, the pharmacies in Canada can import drug and export it to the United States, and that drug does not have to meet Canadian standards for them to be able to do that. So again, like Garth said, we support the intent of addressing drug shortages, lowering drug costs. It's just importation from Canada for a multitude of reasons does not seem to be something that's going to actually accomplish that goal. Florida, as far as I know, right, they were one of the first ones to get approval from the FDA for this type of importation across the board. And as far as I know, Garth, I haven't heard of any success in Florida in terms of that program.
No, I don't think they've done anything with it since they got their approval.
So I think, we could say more, but I think, it's 7 o'clock. I'll stop with that on this unless there's questions.
And I just want to hit quickly on prescription drug affordability boards or PDABs, and they call it here in this legislation. This is the second year that we've seen this on healthcare availability and access boards. The big issue here, and this is the same issue, and you can tie it in directly into the Medicare fair drug use list. That's a product of the Inflation Reduction Act, where Medicare will price set 10 medications. This is the same concept. I think about 8 or so states have passed some type of PDAB legislation. The oldest one is being Maryland. They still haven't got their first meeting established yet. Colorado is the only state that's actually declared a drug expensive, and they had to spend $5 million to say that Enbrel was expensive. I could have done that for them for a lot cheaper. But one of the core issues, whether it's this type of a model or on the federal level, pharmacies, if you set an upper payment limit in that UPL, that's what they use in this language. That's new terminology for us. this upper payment limit, if a pharmacy is not able to buy medication at that upper payment limit or below, pharmacies are already being under reimbursed. And so this is just going to continue to damage pharmacies. To show you the extent of where we're at right now, just with the Medicare list of the 10 drugs that are coming out, NCPA did a survey of membership. 93, almost 93% of members responded back saying they're either not going to carry the medication or they're already limiting the stock availability in their pharmacies of those medications. So unfortunately, what these type of programs are going to do, they're going to create access deserts for these medications. We're going to, in addition to pharmacy deserts, we're going to have medication deserts. And so we've got to find better ways to look at this. And again, comprehensive PBM reform, getting in proper reimbursement, lowering, making sure all rebates go back to the plan sponsors and the patients, help create this. So Laura, why we're against the board creation, because this is doing more than just creating the board. There is some limitations about where they've been open to at least allowing us now to have a pharmacy related individual on there, but because of conflicts of interest, they don't want a practitioner on there, which I think completely dilutes the board. If you don't have a pharmacoeconomist on this board or a health economist, you don't have expertise to properly make a decision about a price point of anything related to medications. And so these are boards trying to do good without educational structure. And that means they're set up for failure. And in Illinois, you can only regulate up so far up the drug supply chain. And in Illinois, they can regulate up to the wholesaler. But to the wholesaler's argument, they're put in the same position as the pharmacy. If they don't have any regulatory leverage to go and ask the manufacturer to give them allowable to be able to purchase that price at the UPL, the wholesalers put into a situation. So it just creates a bad situation for everyone where no one wins. This is a flawed idea. And just to show you, this is actually one of the few issues where pharmacy is on the same side of the PBMs. Because one of the things that we pointed out in discussions last year is that this would be for any pharmacy that services Illinois patients. So if you've got a mail order facility in Ohio, they have to purchase at the UPL. Well, Ohio doesn't have this type of language, so they're not going to be able to purchase at that. So those pharmacies are going to limit the access to those medications as well. So again, patients will be harmed by this type of legislation. Pharmacies could be continued to be pressured to destruction with these type of legislation pieces. We've got a couple other comments. Common themes is lower cost, but it has to go to the top of the federal level to force pharma to lower their prices in the United States and cut out the PBMs. Exactly. We have to have a top-down approach. And another comment, understood. It just makes sense that they're trying to do good. It's a bill of good intention. And for those of us that have been around, sometimes the most dangerous language that ever can be concerned or proposed can be a bill of good intention. Because a bill of good intention does not always have the rationale behind it. Chris, I'll let you wrap us up here with 340B, and then we'll get into logistics.
I think this is, so House Bill 3350, the counterpart, Senate Bill 2385, it really has to do with maintaining patient access to 340B pharmacies. It's Anna Moeller, Representative Moeller, Senators Kaler, Halpin, and Cervantes. And really, long story short, this bill would prevent manufacturers. So we've talked a lot about PBMs. We're going to talk about manufacturers here. It basically would prevent them in several different ways from trying to limit contract pharmacy agreements. So what it would do is we're seeing more and more manufacturers limit access to drug. We see them limit access to how many contract pharmacies they can have. And also they're asking more and more for more claims level data to justify the 340B purchase. In addition, they're looking more and more at ways to make this more of a rebate program as opposed to an upfront discount program. So what this bill would do is basically protect those relationships with the contract pharmacies and the covered entities to say if HRSA, long story short, right in a nutshell, if HRSA says the contract pharmacy arrangement is okay, manufacturers don't have any right to limit that relationship. What you might be asking is, well, 340B is a federal statute. Why would states be getting involved in this? And it's because of the complete inaction on the federal level. HRSA does not have they don't have very big teeth. They don't really have a lot of ability to enforce the 340B statute. They can give opinions on whether or not there's a violation. And there are some things HRSA can do to regulate manufacturers, but it's limited. And so many states have begun looking at 340B protections for their covered entities and contract pharmacies to step in until the federal government is able to get something accomplished. What would you, and this is a bill that we would support. It's not going to be in your sheets because again, we're waiting to really see. You can see it's in the committees that really decide what other committee it might go to, right? It's in assignments and it's in rules. So we'll have to see what's going to happen with it. This is not one you're going to see a sheet for tomorrow.
No, but it is a bill that I know you will be hearing from both organizations later on in session.
Yeah.
This is an idea that I know is getting a lot of traction. I've already had conversations both on the pharma side of the equation and also from the Illinois Primary Healthcare Association, who I believe is pinpointing, trailheading this legislation.
And Illinois Hospital and Health or Health and Hospital
Yes, thank
Association
you.
too. So IHA as well is, in support of this as well.
Yep. So there'll be a lot of good discussions, but there's got to be I think, some sit down between pharma and some of the provider organizations before it can get wheels. So we're going to finish up the rest of our time kind of just quickly going through advocacy and where you kind of fit in, especially for those of you who will. Well, two important things about those who will be joining us tomorrow and in person, and those that will be virtual. So we'll kind of hit this really quickly, and I'll let Chris hit these, and then I'll hit some of the other slides here.
So one of the things, there's a lot of voices involved in advocacy. Sometimes we're on the same page and sometimes we're not, is kind of the point of this slide. So what I'm always happy to say is, you have IRMA or the Illinois Retail Merchants Association, IPHA, the Illinois Pharmacists Association, and ICHP. We get together fairly regularly to talk about legislative issues and concerns and what are, each organization's stance and where are we at. I would say 99.5% of the time we're on the same page overall. It's only every once in a while there's an issue where there's a slightly different view. But we also work with the Illinois State Medical Society. They're often opposed to anything to do with pharmacists' scope enhancement, right? So anytime there's a new thing we can do, they're often opposed. But we work with all these agencies. Sometimes we have worked with Illinois State Medical Society together to accomplish good things. And these other groups. And pharma too, right? It's not always an adversarial relationship with pharma. So for time purpose, I think I'm going to stop there. But just realize, it's very important that pharmacists and the associations express what is needed, and technicians too, by the way. I know we got a lot of techs on the call too, to express what our patients need and what we need for our practices.
And
because other organizations are going to advocate for themselves.
Yeah, and I'll just add there quickly about Med Society and some of the other healthcare provider organizations. Yeah, sometimes we clash on scope issues, but when it comes to a lot of these PBM reform and medical insurance reform issues, we're supporting each other and helping advocate for our patients, because we know the more that we can deregulate a lot of these issues that are happening out there, the better we can help take care of our patients from our respective continuums. So a couple quick ways on how to activate your voice. Of course, some of you are going to be doing that in person tomorrow, and some of you will be doing that virtually. So by attending Legislative Day, and support a pro-pharmacy candidate. As Chris and I both have discussed, pharmacy is not a red issue, and it's not a blue issue. Mike Meinsinger, our chair of our committee, always says it's a pro-mortar and pestle issue. And so we're looking at those pro-pharmacy candidates, and And believe me, we have people from the furthest part of the right on the MAGA side all the way to the most progressive on the left that are our supporters. And so that's where, we have to be politically agnostic on a lot of these issues whenever we're working with legislators from all these spectrums and helping and allowing them to help us as we get our agenda accomplished. And you can simply work for a campaign, bring them into your practice, whether it's community or health system, work to get them into your practice so they can see what pharmacists do. That is the best way to help you. And also reaching out and writing your legislators. Yes, we're going to have some of that here shortly of showing you how you can help write your legislators. And it's about all of our patients because we all have different ways that we help our patients throughout the continuum. Of course, those of you who'll be meeting with your legislators in person, please introduce yourself, state why you're there. Remember, this is the start of a relationship. Again, as I talked with my students, if you have a patient who's just found out they have diabetes, do you tell them in one session everything they need to know about diabetes and everything that's going to help with both their lifestyle and their medication changes? Of course you don't. It's the same thing here with meeting with a legislator. Take it slow, take it one issue at a time, help make sure they have understanding, use those techniques that we have with motivational interviewing to help advocate for these issues. And again, mention common contacts. A lot of times, if you may know someone directly, personally with that legislator, mention those individuals. Stress those key points. Leave those just talking points. Keep it brief. Remember, you're opening up yourself as a contact. There's only 3 healthcare related professionals in the General Assembly right now. We have an emergency medicine physician, a part-time retired optometrist, and a licensed clinical social worker. Everyone else does not understand what healthcare, how it works. And so the reason they know their level of education is because of constituents and advocacy. So again, keep your issues brief and follow up with those thank you letters and email reminders. Chris, do you want to handle the other
Sure.
side of it?
I think, there's a couple things. Obviously, they're people. When you meet with them, don't be rude or ever threaten them. Obviously you don't want to have delusions of grandeur and be talking about how great of a political influence that you have. Or while it is nice to talk about, oh, collegially, I know this person that you know, and those kind of things, do you know who I am? Or do you know who I'm teasing. Do you know who this person is? I'm their friend. That doesn't work. Um, don't promise something you can't get them, right? If they have a different opinion of you, you can't be self-righteous or all-knowing and say like I'm right, you're wrong, and get upset. I think one of the other things, you don't want to be vague about your issue, but at the same time, it's also okay to say, hey, you know what? That's a key piece of information I don't know. Let me talk to Garth, let me talk to Chris, or let me, I'll get that information for you. So don't make up facts or don't provide information that you don't know to be true. Thank them. Also, the other thing is, they know you're their constituent. You don't need to say, I vote for you. I'm your constituent, or I gave you money. Those kind of things. You also do not offer to give them money for their political, campaign or political efforts. That is only to be during fundraising events or very specific designated events that you can do that. Again, keeping it relatively short because we know we've all got all of you on here at 7:15 at night. They're people. I think that's the key statement that I just made. Now, some of them are easier to talk to as people than others, just like any other human being. But overall, when their constituents are there and their students there, they're excited to talk to you. They are at least willing to hear you out and see what you have to say as a person who can vote for them and who is one of their constituents.
So, especially for those that'll be with us tomorrow, we are not the only group on the Capitol grounds tomorrow. It is also, I know one of the larger groups that'll be there. It's also University of Illinois System Day. So there'll be a lot of representatives from each of the University of Illinois campuses. There could be other larger groups there as well. So it can be a little tight as we get around to the Capitol. So I just want to make sure that as we go through, that we take time to process through security and make sure that we enjoy ourselves. That's one of the reasons why we try our best to get most of you appointments tomorrow to make things a little bit easier. Your group leaders will be getting that information emailed to them later on this evening. Those documents are being finalized. We do provide you lunch tomorrow. Remember, we'll be at the State House Inn, just a couple blocks north of the Capitol building. We're providing you talking point sheets. You'll all have group members who have done this before, but group members will help you with the initial interactions. But if they go to your senator, your representative, they're going to push you to be the one to talk because, again, we want that constituent senator representative connection to be built. And that is one of the key points about bringing you to Springfield. And we'll go over a lot of this tomorrow, but I do want to hit on a couple things for those that will be working with us virtually. And then we're going to kind of go over some aspects of the geography of the Capitol campus. So please stick with us here just for a couple more minutes here. For those that'll be joining us virtually tomorrow, we need you to do a couple things. One, we need you to check who your senator and rep is. Not everyone knows that. Plus, with the census, it may have changed. And so we have a couple QR codes. The first one will send you to the IPHA Advocacy Center. You can actually put in your address and zip code, and it'll tell you who your senator and rep are. Again, review the materials for Illinois Pharmacy Legislative Day. If you scan that QR code, it takes you to the program link. Those that are attending in person, you already have that link in your email. You can log on to the Advocacy Center. We have 2 letters that are prompted there for you to interact with. Or you can schedule yourself to make a phone call to your senator or rep. The first one is to Governor Pritzker, continuing to push the need for this, but it's also thanking him for addressing the need for PBM reform in the state. And then for your senators, pointing out to them the governor's push, and then showing on a federal and a state level why this is needing to be done today, and how it shows the Auditor General's report results, and it also talks about the FTC federal reports as well. Then we want you to send those letters or make a phone call, and we want you to post on social media, and that's why I put the slides into the chat, where you can pull these sample posts later on, or you can also pull this handout from the Illinois Pharmacy Legislative Day resources. Then we want you to encourage 10 peers and patients to advocate along with you. This isn't all on your burden. We want you to share in this advocacy experience and help make the voice louder so we're all heard tomorrow and the next day throughout the months ahead until, as I say in our legislative calls, until the ink is dry on the bill. It's not when it's passed, it's when the ink is dry. And then the rest of the work continues. So here are some example posts for each of our primary issues. The first one, the critical need for PBM reform. Some additional post recommendations for the opposition bills advocating for proven PBM reform. And then some posts also for the white bagging issue as well. Then lastly, I just want to kind of go through some geography for those that have never been to the Capitol before. The North Wing is under construction, and so we don't have all entry points available to us. One, you'll need to make sure to bring your driver's license or state ID with you. And entry to the Capitol is going to be the easiest from the east doors. And I know some of you are going, which one are the east doors? For those of you who've been to the Capitol before, where the longer staircase that has Abraham Lincoln's statue out in front of 2nd Street, that's the east doors. That's the easiest one to go through. Or you can go through the west doors on the back end that's in between the Stratton building where the House offices are and the Capitol. But the North Wing entrance is closed at this time, and you'll see some barriers for the North Wing on 1st and 2nd floor. You won't be able to access it at all, or even in the basement level. The 2nd level are where some of the committee rooms are and where the governor's office is, and some of the House Republican staff is also up on the 2nd floor. The 3rd floor, as you see here, the Senate chambers are back in operation, but most of this, if you have appointments with Senate Democratic staff, they're actually over in the north part of the west part of the wing here in the actually the former Republican offices. The fourth floor is where committee chambers are and the galleries for both the House and the Senate. If you want to be able to attend, be able to view the proceedings of the House, they should be in committees when we're over, but I don't think either one will be in session when we come over. And then finally, on the Capitol part, there are some miscellaneous offices that are spread throughout the first, third, and sixth floors. Any of you have leadership meetings with the House Democrats? That's going to be in the third floor, Speaker's office wing. Everybody else is in the Stratton building. Senators primarily have always been in the Capitol, but with the construction, the senators are mostly over in the the first floor of the Stratton building. And so you'll see there, the first floor has everybody kind of split out into different cube sections, or they're calling them, they just call them sections. And this map also shows you for those senators that are back over in the Capitol, they are slowly moving some of them back over. And you'll have printouts of these in your handouts tomorrow, but this is the Stratton building. On the second floor of the Stratton is the primary offices for the members of the House. The east and west parts of the hallway and the south of the building are the Democrats, and the north wing is all the Republicans. There are a handful, as you see here, a handful of Democrats that are also up on the first floor and the fifth floor as well. And if you have time during your meetings tomorrow, after they've been accomplished, and you want to sit in on a couple of committees, there are a couple of committees that are meeting tomorrow. None that are primary to any of our major pieces of legislation. There is a question about where do we park. There is some parking available at the State House Inn, where our major programming will be, where lunch will be, and where we want you to focus in checking in at as well. There will be some street parking around there as well. It's metered parking, but it shouldn't be too bad around there. It's a lot better parking than venues that we've had in the past. So there are more options. There will be limited parking available at the IPHA building, but the IPHA building is on the opposite side of the Capitol complex. If you don't mind to walk, you're more than welcome to park over here. Just leave a little bit of room so staff can get in and out if the parking lot starts to get full and they need to come over for items. Chris, anything else that you would like to add?
I don't think so. I think you covered it. The schedules and stuff tomorrow, with the appointments, I'm assuming those have rooms with them, Garth. Like it'll
Yes,
say.
yes, they will have rooms with them. And one thing I did forget to go over, so again, we'll start check-in at 11 o'clock tomorrow. Lunch starts around 11:30. Chris and I will do an abbreviated version of this program and any additional updates at 12:30. We do have some scheduled guests that are going to be coming over from Medicaid that will be addressing any questions that you may have concerning Medicaid. We may have some additional guests from other departments or legislators coming over. And then we also have, if you live in Missouri now but are representing a hospital in Illinois, will I not be assigned to a meeting? No, those of you who are out of state, we've assigned you into groups, and hopefully, and Shannon will just make sure we touch base with you on your question to make sure that that we have you going to your senator and rep that represent that cover your hospital. I want to make sure that we get that. And then at 2:30, as those of us, so we'll be progressing over to the Capitol around 2 o'clock. At 2:30, we will be having a press conference in the Blue Room in the basement. I don't recommend everybody coming down there. It's not like last year where we were outside around the Lincoln statue and there was a lot of room and we wanted all the bodies there for the visuals with the cameras. The Blue Room's a very tiny press spot, but both organizations will be holding press comments, delivering press comments, and we'll be joined by Bill Schmitnick, the father of Cole Schmitnick, delivering remarks about about, as a patient advocate, about the experiences that his son, unfortunate experiences his son had that led to his death, and last year. And so, Bill, we're very glad for him to be coming and joining us. He's driving down from Madison. Actually, I think he's already in town. So we're glad to have him with us to share his family's story about why PBMs need to be reformed and the dramatic impact it has on people's lives that are not always brought to light. Chris, any other questions or anything comments I'm missing from anybody?
Not that I saw. I think
Okay.
we hit it. Tomorrow, the only thing I would say is Garth and I are both going to be there all day tomorrow, along with staff from both organizations as well. So if you have a question, you have a concern, find one of us and we will do everything we can to help you, figure things out.
Yep.
Whether
And
that
what
be wayfinding, whether it be questions about the bills, like you want a little bit of clarification, those kind of things, find a staff member and we'll be able to assist you.
Yeah. And I just want to say thank you again for everyone coming down. Advocacy is a journey and it's a long and winding road at times. It can be very frustrating for some, but we want to make sure that your voice is heard, that all practices are represented, and that we're lifting everything up for our patients. And so we'll see everyone tomorrow. I look forward to seeing the posts going out for those that aren't able to join us in person. And thank you to everyone for lending your voice for advocacy. Thank you.
Thank you, everyone.